What is nausea and vomiting? Nausea is a sensation of wanting to be sick or vomit. It's a diffuse sensation of unease and discomfort, often with profuse sweating, increased salivation, pallor, increased blood pressure, and tachycardia. Vomiting or emesis is the expulsion of the contents of the stomach through the mouth or nose, often very violently. They may occur together or independently of each other. Nausea and vomiting can be acute, 1 to 2 days, or chronic, with chronic lasting greater than 1 month, depending on the cause. So let's have a look at that now. Nausea and vomiting are protective defense mechanisms to avoid potential ingestion of toxic substances, such as drugs, viruses, and bacteria, either entering parenterally or enterally. It's triggered by diverse stimuli through the central and or peripheral nervous system, and there are 2 key sites in the CNS involved in the vomiting reflex. These are the chemoreceptor trigger zone and the vomiting center, which is located in the middle left. This center receives input from various areas of the body. We have stimuli from the vestibular and visual system, the GI tract, the chemoreceptor trigger zone, and the CNS. 5 neurotransmitters that feed back to this area are highlighted on the screen there. This is where the drug therapy is targeted, which we will discuss later. So now we have some causes. The first one is gastrointestinal. Chemoreceptors and the caloreceptors in the GI tract can sense various chemicals and mechanical or distension stimuli. So if you eat so much that you feel like you might burst, you will also probably feel sick due to the chemoreceptors feeding back. So we have gastroenteritis, which is an infection in the GI tract causing sickness and diarrhea, generally caused by viruses or bacteria. We have GERD, or gastroesophageal reflux disease, peptic ulcer disease, gastroparesis. This is the delayed gastric emptying. It's thought to be due to nerve damage affecting the stomach muscle movements. Bowel obstruction, appendicitis, gallstones. This happens if a stone blocks one of the bile ducts. Dyspepsia, and alcohol abuse. This is due to a direct irritation of the stomach lining and also a slowing of the digestion and, of course, dehydration. Some CNS causes more. You have migraines. The nausea is often associated with the pain of the migraine. Connections between trigeminal neurons and the nerve-based trapped fluoritis explain the nausea and combinationally the headache. Brain tumours increased intracranial pressure, causing sickness. Head injuries, such as concussion. Sunstroke, due to the failure of the body's temperature control system and dehydration, and infections such as UTIs. Now on to vestibular. We have histaminolergic and muscarinic receptors that can be targeted for drug treatment here. And some of the conditions that can cause nausea and vomiting are listed here. Motion sickness is triggered by excessive stimulation at the vestibular system or conflicting information between proprioceptors, visual, and vestibular sensory inputs. The brain estimates motion based on the combined input from these areas, and if they are in conflict with each other, motion sickness will occur. And lastly, we have ear problems such as labyrinthitis, Meniere's disease, and vertigo. And from the metabolic causes, we have uncontrolled diabetes, a complication of diabetes, such as diabetic ketoacidosis, can cause persistent vomiting. Hypocalcemia, a high calcium level is most commonly due to a parathyroid gland overactivity. The kidneys will need to work harder to filter it, causing thirst, frequent urination, stomach upset, and vomiting. We have hyponatremia, adrenal insufficiency, and liver cirrhosis. The body has diminished ability to process and eliminate toxins, resulting in a persistent feeling of nausea. And for miscellaneous, we have drugs such as opiates, iron supplements, chemotherapy. The chemoreceptor trigger zone can be stimulated directly by drugs or their metabolites. Drug overdose, toxicity, and polypharmacy, where multiple drugs are taken together. This can increase the risk of nausea as well. We have pregnancy or morning sickness, or in severe cases, it's termed hyperemesis gravidarum. The exact cause of this is unknown, but it's thought to be due to the rapidly increasing HCG levels in the blood. Psychiatric disorders such as anxiety, depression, hysterical neurosis, and post-operative. This is a miscellaneous category as it can be caused by the anesthetic, dehydration, prolonged surgery, and the post-operative need for opiates to manage pain. So I won't go into the investigations needed to determine the cause. Nausea can be pretty non-specific and have many different etiologies, but blood work and a bit of investigation is needed for methods particularly obvious, such as the nausea associated with a migraine. Let's move straight on to treatment. Okay, so remembering from earlier which receptors are involved in the pathophysiology, and give yourself a reminder if you need to and go back. I will group these treatments into their respective classes and discuss each in turn. Treatment generally falls into two categories: medicines directed at suppressing nausea and vomiting, or antiemetics, which usually act centrally, and agents which modulate gastrointestinal motility, termed prokinetics. Let's start with the prokinetics, which increase the gastric motility. These are metoclopramide and domperidone. Metoclopramide is a dopamine receptor antagonist widely used to treat GORD, diabetic gastroparesis, and nausea and vomiting in chemotherapy patients. It antagonizes central and peripheral D2 receptors. Its usual dose is 10 mg 3 times a day. It's used in acute migraine, delayed chemotherapy-induced nausea, prevention of post-operative nausea, and in palliative care. It has some extrapyramidal symptoms, which means an increased motor toe and involuntary movement, such as akathisia, a feeling of restlessness, dystonia, where the muscles contract involuntarily, Parkinson's symptoms, and tardive dyskinesia, which is involuntary facial movements. Also causing a rare side effect called hemolytic malignant syndrome, which has symptoms such as pallor or paleness, tachycardia, hypothermia, muscle rigidity, and cardiac arrhythmias. These side effects stem from blocking dopamine receptors that are generally reversible on withdrawal of the medication. It can also cause dizziness, drowsiness, diarrhea, and a dry mouth. Domperidone is also a dopaminergic antagonist, but has severe cardiac adverse effects, so metoclopramide is generally preferred. It was available OTC all over the country in the UK until a few years back, when it was removed and reclassified as a prescription-only medicine due to this reason. Out onto phenothiazine. Examples are prochlorperazine and chlorpromazine. They're also anti-dopaminergic agents, non-selectively targeting D2 and D3 at higher doses. They have also activity at other receptors when the dosages are high enough, such as H1 and muscarinic. Some of the usages are just on the screen there. They're very good in vestibular causes such as motion sickness, vertigo, labyrinth disorders, and acute nausea and vomiting, acute migraine, etc. Some of the side effects are on the screen there. You have the movement disorders as discussed in the last one due to the dopaminergic blocking, and also we have antimuscarinic effects such as dried mouth, blurred vision, etc. Antihistamines. These exert their antiemetic effects through central anticholinergic M1 receptors and antihistamine H1 receptors. Examples are cinnarizine and cyclizine. Mostly used by vestibular causes of nausea and vomiting, such as vertigo, tinnitus, nausea and vomiting in many years, and motion sickness. And so with the side effects on the screen there, the usual antimuscarinic ones are also there. On to anticholinergics. These act centrally via muscarinic receptors and block the pathway from the inner ear to the brainstem and the vomiting centre. An example is hyoscine, known as scopolamine in some countries. You can read in the US. It's most widely used, usually administered via a patch or a tablet for prophylaxis and treatment of motion sickness. Its use in other forms of nausea is not well established. The usual antimuscarinic side effects apply: dry mouth, constipation, etc. Also headache, dizziness, flushing, skin reactions, and palpitations. On to the last category now, serotonin 5-HT3 antagonists. These block the 5-HT3 receptors in the chemoreceptor trigger zone and the GI tract as well. An example is ondansetron. It's used in post-operative vomiting, post-radiation therapy, preventing chemotherapy-related emesis. Some of the side effects are constipation, feeling hot, headache, arrhythmia, chest pain, hiccups. I thought the last category was the last, but it's not, so there's one more. neurokinin antagonists. These bind to NK1 receptors in the vomiting centre, preventing substance K1 binding here. It's for therapy-induced nausea and vomiting, such as apipupitant, side effects are reduced appetite, constipation, GI discomfort, headache, and hiccups. There are other classes of drugs used as antiemetics, which I won't discuss in this video as it's covered along enough already. They are cannabinoids, corticosteroids such as dexamethasone, and benzodiazepines such as orazepam.